بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. Today we have pathology 1 revision, MOOC 1. We have three pathology MOOCs. We'll start today by pathology 1. By the way, most of the questions for today answered from real exam stations, from the real checklist. So don't be worried about what is the checklist. So all the discussion today will be discussed from the real checklist and the latest answer accepted by examiner inshallah. Okay, يلا start.
Okay, Dr. Mustafa, Dr. Mark, Dr. Tadros, and Dr. Nidal, please raise your hand so I can recognize you and unmute your mics.
Nadashi is busy today.
Okay, so now Dr. Mark and Dr. Tadros with me. I will start with Dr. Tadros. This is the same for your station. A 32-year-old male presented with right groin lump, firm and tender for a month. On examination, testicle not palpable in the scrotum. Ultrasound showed 6 centimeter partially cystic and solid mass at internal ring extending into the abdomen and local soft tissue. No other organs seen. Dr. Tadros, did you understand your STEM? Hello, Dr. Tadros? He unmuted himself. Dr. Mark, are you with me?
Yes, I am. Hi, Susan.
Hi, how are you?
Not too bad, thanks.
Okay, so what is your differential diagnosis?
Right groin mass, possibly a malignant lesion, probably testicular carcinoma that's metastasized to the origin, or infective causes like other lymphadenopathies as well, or it could be an inguinal hernia, possibly, or probably a lipoma as well. But given the age, I think, and the description, I'll go with testicular carcinoma.
Okay, orchidectomy and bone biopsy from the suspicious region done, and pathology report came as follows: testicular teratoma with involved margins, local tissues, lymphatic and skeletal invasion. Discuss this pathology report with the family in simple lines.
In simple layman English, this is a cancer of the testis. It has there is incomplete resection. It might need further surgery. It has spread also to the lymph nodes. There is involvement of the muscle and the bone.
Excellent. To where does teratoma initially spread?
Because the para-aortic nodes.
What are the types of testicular tumors according to the age groups?
I'm not sure I know this one, but I think we have seminomatous and non-seminomatous, and then we have the teratomas, and then we have the sexstroma tumors as well.
What about the age groups here?
This one I'm not sure. No, I don't know it.
Which one come in young age and which one come in older?
So seminomas are mostly above 30s, and then over 60 years, mostly the non-Hodgkin's lymphoma. Below 30, probably teratoma, I think.
Excellent. What's choriocarcinoma?
Choriocarcinoma is a non-seminomatous cancer. It's highly malignant. Other features, I'm not sure the other features. That's what I can remember.
Originating from which tissues?
Yeah, it has to be from the germ cell, the intratubular germ cell neoplasm. Somebody has said placenta. Right.
Yes, placenta-like tissues. What tissue section immunohistochemical marker confirmed diagnosis of choriocarcinoma?
HCG.
Yes, beta HCG. What other type of malignancy at this age? Patient was 30s.
Was in her 30s, so possibly seminoma.
Yes, the differential is seminoma.
Okay.
What's alpha-fetoprotein?
Alpha-fetoprotein is a tumor marker, mostly coming from the yolk sacs and also from liver tissue. So it can be high in malignancies of the liver and also with yolk sac tumors.
Mention another non-germ tumor with high alpha-fetoprotein.
Hepatocellular carcinoma.
What is the value of LDH in testicular cancer?
Essentially, it can help with for us to know tumor burden and then also the progression of the tumor. And also we can use this as a marker to determine.
It is not a marker. It is not a tumor marker.
Possibly it could be a marker, isn't it?
No, it is not a tumor marker for testicular cancer.
It's non-specific, but I think.
It is not a tumor marker for testicular cancer, please.
Okay.
Okay, its value here, it reflects the tumor load, rate of growth, but it is not specific marker for testicular cancer. So do not mention it as a marker.
Okay, all right.
Post-operative developed hematoma. What are the stages of hematoma resolution?
We have the cloid lysis by macrophages and then formation of fibrin with fibroblast. Mostly the clot lysis takes within 1 to 3 weeks, and then the fibroblast after 3 weeks.
Lysis within 1 week and growth fibroblast 2 weeks.
3 weeks, okay.
After a few months, he developed a small pneumothorax. What could be the cause?
Possibly metastasis to the lung.
Define metastasis.
Metastasis is survival and growth of cancer cells at a distant location from their primary origin.
Excellent, Dr. Mark. Dr. Salah, do you want to add anything before we discuss another stem?
No, continue for another stem, Dr. Suzanne.
Okay. Dr. Haifa?
Okay, first, this is a stem before this recent stem. And the stem now will be discussed now. I think this is from the checklist. صح كده سوزان؟
This is the most recent one, yes.
اللي خلصناه دلوقتي كان ايه؟
This from the checklist.
So the checklist finished. And this one, the recent one, the recent one. By the way, this station came in Dubai, December. And by the way, also, December in Dubai was Edinburgh. This is the recent stem. يلا.
Okay, Dr. Widat, please unmute your mic. Dr. Tadros, are you here?
Yeah, I am here.
Okay, Dr. Widat, keep beside. Don't be away. We will take you after him. Okay, the second stem, a 69-year-old male presented with bilateral groin lump, firm and tender for a month, gray scale and color Doppler ultrasound. Findings include diffuse testicular infiltration, enlargement with hypervascularity, or multifocal areas of hyperechoic solid and hypervascular nodules within the testes. Orchidectomy done and testicles found white, tan, pink, and fleshy. The pathology report came, malignant cells are polymorphic and non-cohesive with large irregular nuclei and prominent nuclei with vascular invasion and sclerosis of the seminiferous tubules. No intratubular germ cell neoplasia. The neoplastic cells typically express CD20. Are you ready, Dr. Tadros?
Yeah, I am ready. Yeah. Yes, I'm
On the
ready.
light of the pathology report given, what is your diagnosis?
Lymphoma.
You are asking or answering?
I am answering.
Okay, so answer in answer form, please.
Yeah.
Talk about classification of testicular tumors and give an example for each.
For testicular tumor, germ cell tumor, and non-germ cell tumor. For non-germ cell tumor, lymphoma. For germ cell tumor, there is seminomatous tumor and non-seminomatous. Seminomatous tumor, seminoma, and spermatocytic seminoma and anaplastic. Non-seminomatous, there is teratoma and choriocarcinoma and embryonal carcinoma.
Excellent. So if the examiner asks you a big question about classification of testicular tumor, you can mention the pathological classification and the age group classification. If the question is specific for each of them, mention the one you ask about only.
Yeah,
Describe
okay.
the microscopic morphology of testicular teratoma versus seminoma.
Microscopic morphology. About, I don't know, sorry.
Seminoma is sheet of uniform cells divided into lobules by delicate fibrous septa containing lymphocytes. Cells are large and round with large nucleus and prominent nuclei. Cytoplasm of tumor cells has glycogen. Positive for PLAP, OCT4, stains, and CKIT, CD17, 117, sorry.
Okay,
While
I'll revise it.
teratoma is a tumor composed of various different types of cells or origin component, any age, infancy to adult life. It is pure form, it is common in infant, and so it is tumor composed of different or variant types of cells of origin, okay? This is about
Okay.
teratoma because it is teratoma like any other teratoma.
So make it simple for them, Dr. Suzanne. This question asked once only. Is the histological appearance or difference, pathological difference between them? Teratoma composed of various different types of cells or organs components at any or organ components, like thyroid tissues, all this way. While seminoma, you should explain exactly what is seminoma. So microscopic morphology for it is you form cells divided by fibrous septum containing lymphocytes. Is the nucleus will be large as any cancer and will have a prominent nuclei. Yani this is enough here.
Okay.
Okay, he presented with PE a year later and found to have large mass at the region of para-aortic lymph nodes, compressing renal veins. Debulking surgery done, but tumor can't be totally resected. Frozen section showed thyroid tissues. Why?
Because there is 3 germ cell layer, endoderm, ectoderm, and mesoderm.
And because it is teratoma, and teratoma
Teratoma, yeah.
differentiated
Yeah,
in the
teratoma.
different cell pathways from the 3 germ cell lines.
Okay.
Explain finding in adenocarcinoma.
I don't know. I don't know the question. Sorry. Explain finding.
Pathologically, what will you find in adenocarcinoma?
You want the definition or the?
It is epithelial differentiation and
Yeah,
subsequent
epithelial
horizontal
different
transformation of epithelial differentiation line.
glandular structure. Yeah.
What is the composition of PE?
The sequence or the composition of the what happened?
Composition of PE.
Platelet and polymerized fibrin and mixed cells, red blood cells.
Circulating cells, yes, excellent.
Yeah.
Which clotting factor allowing polymerization of fibrin?
factor 13.
No.
Factor 8. Factor 8. I asked
Eight.
Dr. Salah.
Activated factor 8, yes.
Yeah.
What
Wait,
cause-
wait.
I'm sorry يا باشا. معلش يا باشا.
لا we reached for this question. By the way, يعني if I have the checklist, I will answer it by any other factor. But really, it's written in the checklist by this way. Yes, yeah, Dr. Mansour, I know how is factor 8. We don't know how is factor 8, but in the checklist, in the really checklist. شباب يعني التشيك ليست ديت يعني ده اللي بيمتحن من الممتحن. يعني I can't object for it. So I will tell you what you should do. I will tell you يعني ماشي بس مكتوب كده. So this is your mission. Do what you want. You want to tell factor 2, he will ask you what else, what else. So tell all factors you want. You are convinced, but written in front of him factor 8. تمام؟
Okay.
What caused pulmonary embolism in this patient? Explain.
Workout triad, hypercoagulable state, and venous stasis, and vascular injury, procedural injury.
I finished this station, Dr. Salah. Do you have any more questions
Thank
for
you.
Dr. Mark and Dr. Tadros? Or you have any comment?
No, the action. What is the name of teratoma in the ovary?
Ovarian teratoma. No, I don't know.
Anybody can tell?
Ovary.
ما هي بقى؟
Stroma of ovary. Ovary.
Right. Stroma ovariae. This asked before. Okay.
Okay.
Right. We finished from this station. Still, I have some updates. Dr. Suzanne. Okay. I'm opening the notes group. She asked in the first step about beta HCG. Beta HCG can be released from male or not. This is asked in Dubai this time. Beta HCG, this is specific for cholangiocarcinoma. Can be released from normal male or not? And in which situation? So if the question by this way, most will tell yes. Testicular tumor. Normally, I told in normal male, sorry, I told in male, not normal male, not in cancer. I'm telling in normal male, sorry. Can be beta HCG. This is specific for female for pregnancy, as you know, for pregnancy. But can be released from normal male or not? Yes, can be. There are two potential sources of beta HCG that act on sperm itself, and which named seminal in the seminal plasma, in the semen, in the sperm, in the plasma around the semen. This is normally can be released, and the other one for female reproductive tract, and both of them are normal. يعني released normally, not cancer. Okay, this question, one of the question asked in Dubai last month.
So female reproductive tract is part of a normal male? I didn't get it, sorry.
normal يعني without cancer يعني سوزان ده المقصود يعني.
But the question is about the normal male.
And also normal ما انا عارف انا بقول لك ان انا بشرح ان في سورسز في سورسز للبيتا اتش سي جي.
Because they got confused, not only me.
لا انت اللي كونفيوز مع نفسك. انا كتبت في السؤال ان ممكن يتفرز نورمالي في اثنين في تو سيتويشنز يعني منهم الميل يعني بس في الميل ان ذا بلازما اراوند ذا سيمن. اوكي. انت ما شفتش السؤال ده قبل كده يا سوزان؟ انت معناته انك مش ابديتد، معناته انك مش كواليفايد. زي اللي بعت لشنوده يساله يقول له ايه، انا ممكن اسالك انت نجحت في الMRCs ولا لا؟ قال له ليه بتسالني؟ ده واحده يعني عشان اشوف انت كواليفايد انك تشرح MRCs ولا لا، تدي كورسات ولا لا. ده احنا شايفين مرار على الخاص. نكمل. Testicular tumor, age 69 years with testicular swelling, asking 3 differential diagnoses. I remember in updates 3 differential diagnoses: seminoma, teratoma, lymphoma, secondaries. Some told me Dr. Salah knows a question not by this way. He's asking what is the types of cancer in age of 70? Only lymphoma and secondaries. No, he asked for 3. I don't know how the question is asked, by the way, but I think will be accepted seminoma, teratoma, lymphoma, secondaries, and they will tell about teratoma and seminoma, very rare in this age. Okay. The two situation in the notes group now, in the notes group. Yes, in healthy man present. يا شباب ما تقدروش. بقول لكم انا طالع من بارت بي جاي الجزء زي بارت ايه coming for scientific discussion. Okay, so don't ask this type of questions. It's written in front of you. Why beta HCG released from normal male patient when there is 2 potential sources in general. One acts on the sperm. This is the seminal plasma, another one in female. Okay, it's written. ما انا بقراكم منين؟ بقرا من مكتوب قدامكم. It's three differential diagnosis: seminoma, teratoma, lymphoma, secondaries. Histopathology report: there is lymphoid cells, CD20. So what's the diagnosis now? Lymphoma. What investigations you will do? Okay, investigations you will do generally for testicular tumor. You will tell about tumor markers. You will tell about differential diagnosis for it, like inflammatory markers, because maybe orchitis. You will tell about imaging, ultrasound, CT scan. After that, I will go for staging and grading by CT, chest, pelvis, and abdomen, and after discussion with multidisciplinary team. Yes, انا بص يا حسن، انا مش مقتنع. يعني other differential in this age group. We will open the mic for you. We will open the mic for you. افتح الحسن سراب. ماشي. طيب. Patient received chemo radiotherapy after 2 years with ulcer in his face. Biopsy was taken. Characterized epithelioid cells revealed squamous cell carcinoma. Mentioned 2 causes or risk factors for this patient to have squamous cell carcinoma. Number 1, exposure area in the face. Number 2, post radiation, low immunity. What you will look for in histopathology: I will look for the size, margin, depth, lymph node affected, blood vessels invasion, and neurovascular. You will tell about neurovascular invasion, يعني lymph node invasion, blood vessels invasion, and neurological invasion. Okay. Investigations of lymph node: fine needle aspiration cytology. استنى ما اخلص. Fine needle aspiration cytology, and what else? There is fine cytology for lymph node. There is lymph node and invasion of blood vessel. How tumor is spread to lymph nodes. We will discuss this question in detail. تمام يا شباب. طيب في حاجة تانية اتقالت؟ So testicular tumor. I think the histopathology report in other center, patient was 69 and stem excluded in a focus of intratubular germicinioplasm, mentioned the polymorphism, presence of keratocytes, and CD10 or 20. I can't remember what is written exactly. Ask diagnosis as we told lymphoma. Then we'll ask you about this is basal cell carcinoma or squamous cell carcinoma. Sorry, what is the cause? Because radiation and exposure area. This is a pathological classification discussed before. Seminoma and teratoma histopathology. Nothing more about this station. حسن.
ايوه دكتور صلاح، كيف حالك؟
عندك حاجه زياده غير اللي اتقالت؟
لا، هي بس الفكره بس بتاعت الليمفوما، هو طالب انه yes sorry regarding lymphoma he's insisting what other than lymphoma?
Secondaries.
So I told him secondaries. He wants something. I don't know what is it.
Tell him teratoma and seminoma.
I did not mention teratoma.
Tell him teratoma and seminoma. Some told me he was accepting this answer, but he will tell this not in this age group.
Yes. Regarding the CD20, also he asked something. I don't remember the question regarding the CD20.
Okay. So You will tell polycarcinoma or type of cancer. So station going like the discussion now with Suzanne or selecting.
Yeah, exactly.
شكرا يا حسن. And also
Exactly.
in Dubai, going by this way, or the only question about beta HCG can be released normally in male, not in female, or not. يلا next station. شكرا يا حسن.
عفوا.
يلا سوزان الحاجة اللي بعدها.
Next session will be with Dr. Widad and Dr. Isra. We'll start with Dr. Widad. Dr. Widad, are you ready?
Yes, good.
A male patient, no case of HIV, hepatitis B virus presented with red groin mass after injection to the groin. What is HIV virus?
HIV virus is single-stranded RNA retrovirus.
Again.
Single-stranded RNA retrovirus.
Okay.
What are the subtypes of HIV?
HIV1 and HIV2.
What are the characteristics of HIV?
It is retrovirus transmitted through body fluids. It can be transmitted sexually and through blood, and non-sexually through transmission like from mother to her infant or during childbirth, and also with breast milk.
What are the causes of true and false aneurysm?
True aneurysm, it can be congenital, like in Marfan syndrome and Ehlers-Danlos syndrome, and can be acquired like in atheroma or in infection like in syphilis. False aneurysm can be due to trauma, or repeated injection at the same time site, like intravenous drug users.
It could be secondary to surgery. What layer is affected in pseudoaneurysm?
Subintimal layer.
Okay, thank you, Dr. Widad. Dr. Isra?
Yes. Assalamu alaikum.
Walaikum assalam. Why does he have bleeding, this patient? Why he's bleeding?
Yes, the first maybe from trauma, and second cause because of the liver involvement affecting the coagulation factors.
What are the precautions needed to stop this bleeding?
As we said, because of the liver involvement, so vitamin K, dependent clotting factor, which include
I'm not asking
10,
about
9,
the
7, 2.
treatment. I'm asking about the precautions you need
Yes.
to stop this bleeding. Precautions.
Yes, precaution, it should be double gloves, mask, apron, eye protection.
You keep pressing on his wound, but bleeding doesn't stop. Why?
Yes, because of the liver involvement, which depend on affection of vitamin K dependent clotting factors 10, 9, 7, 2.
What is the sequence of clotting?
First of all, injury to the blood vessels will lead to platelet aggregation, platelet plug, then activation of intrinsic factor.
Why are clotting factors not working properly?
Yes, I think all of these questions has same answer because of involvement
But
of
because
yes.
I ask you this question and examiner will ask you these questions, you have not to mention this sentence at all. Just answer the question, please.
Okay. Due to liver affection, which depend on the vitamin K clotting factors 10, 9, 7, 2, low CD4, and damage to the bone marrow where blood cells are produced.
What damage the bone marrow? What caused bone marrow damage? Full answer, please.
I don't know actually.
Because this patient is HIV patient, he has low CD4 count, and this lead to bone marrow damage.
Yes.
You see, it is not the same answer for all questions. Okay, I think this is session, Dr. Salah. Do you want to add anything or any question or any comment to Dr.
Go
Vidar
back.
and Dr. Isra?
Go back. No, next page. Next slide. You keep pressing on the wound, but bleeding hasn't stopped. Why? Again?
Because the liver involvement and affection of vitamin K dependent clotting factors 10972.
So, because of coagulopathy only?
I'm not sure. Yes, thrombocytopenia also maybe.
Yes, you should mention only, not this. Affection of the liver on the platelets. Okay, effect of liver on platelets. Okay. Yeah. So, Suzanne, you continue. I think high pressure inside the, no, not this one. Not high pressure, not in this one. Not in this one. And it can be also, but this femoral, not like carotid, not like the carotid one, not like in carotid. It will come high pressure. Okay, I think, this station was new, by the way. This one overdated station. So we have nothing to be added. يلا سوزان.
Okay, Dr. Nazeen, Nusrat, and Dr. Tuna, please raise your hand so I can recognize you and mute your mics.
Assalamu alaikum, ma'am.
Alaikum salam, how are you, Nusrat? So
Yes,
Dr.
I'm
Nusrat
fine.
will be there and next, and after you will be Dr. Hassan. Kirsten is a young lady in a case of chronic renal failure, developed secondary hyperparathyroidism. Now she developed renal stones, blood results available. How hyperparathyroidism causes renal failure?
As this patient has CKD, so there is less 1-alpha hydroxylase. So vitamin D cannot be converted to its active form calcitriol. So it results in decreased calcium absorption, and there is low serum calcium. And also due to reduced GFR, there is a phosphate retention and high serum phosphorus. So this low serum calcium and high serum phosphorus, it stimulates the parathyroid gland to release parathormone, and it results in secondary hyperparathyroidism.
Why? What is the lining of urinary tract?
Stratified transitional epithelium.
What is the type? What are the types of stones? Do you know?
Calcium oxalate, calcium phosphate, uric acid stone, cystine stone, and struvite.
Excellent. What are the genitourinary complications of stones?
Deterioration of renal function, obstruction, pyelonephritis, pyelonephrosis, infection, sepsis, and fistula rupture, and carcinoma.
What are the treatment for renal stones?
If a stone is less than 0.5 centimeter, then conservative treatment, and the patient must not have a single kidney, and there should be no signs of obstruction. If the stone is less than 2 centimeter, then extracorporeal shock wave lithotripsy, but it is contraindicated in some cases, such as abdominal aortic aneurysm, pregnancy, and a stone in the lower pole. Then percutaneous nephrolithotomy in case of complex stone more than 2 centimeter, or if the stone is in the lower pole and more than 1 centimeter. If the stone is in the lower pole and less than 1 centimeter, then flexible ureteroscopy. Then nephrostomy for the obstructed kidney can be done by stenting or nephrostomy tube. Then nephrectomy if the affected kidney has already failed or there is less than 50% renal function.
Excellent. What are the different modalities for management of renal stones? I think you answered already. What are the risk factors for renal cell carcinoma, and how can stone cause cancer?
Tobacco and tobacco, hypertension, obesity, particularly in female, unopposed estrogen therapy, exposure to asbestos, petroleum, and heavy metals, and end-stage renal disease, chronic kidney disease, acquired cystic disease, tuberous sclerosis. Stone causes chronic inflammation, and this leads to proliferation of the urothelial cells, and ultimately it leads to cancer.
Excellent. Okay, thank you, Dr. Nusrat. Dr. Hussam, continue with me. What
Okay.
is the most common renal cell carcinoma?
Yeah, squamous cell carcinoma.
The most common type of renal cell cancer or carcinoma.
Clear cell carcinoma.
And what is the second most common type?
I don't know.
Papillary carcinoma.
Okay.
What are the macroscopic findings in renal carcinoma in reference to pathology report?
I don't see in pathology report. I'm sorry,
What
but
is the macroscopic feature in a pathology? What will you look for? What will you find in a renal cell carcinoma? What will you find in the report to tell you that this is a renal cell carcinoma?
I'll
What are
find
the
the
features?
feature about. He means that I will tell about the features, polymorphism and something like this. It's
You have
macroscopic. Oh,
specific pathological features for clear cell cancer and papillary carcinoma. Do you know them?
no, I don't know. I'm sorry.
Okay, clear cell cancer arises from proximal convoluted tubules, solitary unilateral, bright yellow, gray, white, spherical masses. Margins are sharply defined and confined. Prominent areas of cystic softening or hemorrhage. While the papillary arises from the distal convoluted tubules, it's bilateral and multiple, less vibrantly orange yellow. Papillary formation with fibrovascular course, and there is necrosis, hemorrhage, and cystic degeneration. This is
Okay.
macroscopically.
Okay.
And the next question will be the microscopic. For clear cell and cancer, it's rounded or polygonal shape and abundant clear or granular cytoplasm, which contain glycogen and lipids, while in papillary, it is cuboidal or locolumnar cells arranged in papillary formation, and there will be interstitial foam cells, pneumoma bodies, and the stroma is usually scanty. You have to keep this because asked recently. What is R1? What does it mean?
I'm sorry, but I'm not preparing for this one station. Could you answer, please?
Dr. Nusrat, could you answer the last question, please?
Yes, it is the microscopic residual tumor.
Okay, Dr. Salah, I finished this station. Excellent, Dr. Nusrat. Do you want to add any question or you have any comment for Dr. Nusrat?
No, she's great by the way. Well prepared from part A. مش واحد يقول لك الفرق بين الفوليكولار والبري كارسينوما بتاعت الثيرويد. طيب. She's well prepared from part A. I know. Even her score in part A, not expected. She should score more than 90. But we
I'm
will.
very scared, so
Okay.
it might repeat in part B.
First, we have comment about aneurysm and pseudoaneurysm. I shared for you picture about aneurysm and pseudoaneurysm, the difference between them. Pseudoaneurysm will be dilatation in all layers, while pseudoaneurysm collection of the blood only between the media and adventitial layers. Okay, subintimal. You can tell subintimal. Okay, so finish from this question. If you want to change your answer, give me the evidence. هنرجع لبارت ايه تاني. Give me the evidence before changing, because accepted subintimal accepted. So why you're not accepting our answer? If you will go and tell the examiner subintimal and not accepted, tell me to change. Okay. This is the first one. Renal cell carcinoma came in Cairo, December, in day 1. Okay. came by, you will find microscopic picture which indicates it is cancer. You will find microscopic pathology which indicates that it is cancer. STEM, adult polycystic kidney with renal failure. So you have another case about polycystic kidney disease. Yeah, the confusion in this station. Some candidates, they went, oh my God, and they prepared themselves that this is polycystic kidney. No, the stem of polycystic kidney is different. Here you will find in the stem outside that patient has adult polycystic kidney and he has picture of renal impairment plus very important word to go for this station, secondary hyperparathyroidism. So you will go in this station to secondary hyperparathyroidism. So this is the first question will be why? What is the mechanism? Like Nusrat explained now, and like written in the station in our book. So we have nothing more to be added except I added for you the types of renal stones and management of the stone. I shared for you from part A papers, okay, plus microscopic and microscopic appearance already shared. So sorry, you have only one question about histopathology. So try to keep it. I shared already for you in the notes group by also simple way, not other like our book. So go for notes group only for microscopic and microscopic picture of papillary cell cancer and clear cell carcinoma. By the way, the one who summarized it, Muhammad Al-Awad. I hope, because he's giving courses now, I hope him also when explaining for people some things from our course to tell this is from Salah teached me, but he will deny. But I will not deny. Microscopic and microscopic picture, this, by the way, done by Al-Awad. He told me, Salah, I found very simple things. I told him, give me and I will see. Then I approved it. I told, okay, accept it. Okay. يا ريت الناس يكون عندك كلها ضمير زيي ولا ما عنديش ضمير يا سوزان. شكرا طبعا. يلا كمل.
Okay, Dr. Yasmin, are you ready?
Inshallah. Assalamu alaikum.
Alaikum salam. Your voice is not clear, Yasmin.
Hello. Okay.
ادينا لجنه صعبه. ادينا لجنه صعبه يا سوزان. انا عايز اشوفها في الصعب. ادينا واحده صعبه.
I can't hear her.
هو شكلها صعبه شويه معاها. واحده صعبه شويه معاها.
أنا أسمع هيك. أوكي.
انا سامعها، هي سامعها، صوتها واضح. بس هي بتتكلم ليبي، بتتكلم ليبي. ما تاثرتش لسه بمصر، ما تاثرتش كتير بمصر، فيعني بيبقى في صعوبه شويه.
Okay, Rustemi, the venous ulcer in forearm not healed, biopsy taken. In biopsy report, what are the criteria of malignancy you look for?
High mitotic figure, polymorphism, hyperchromatism, undifferentiated cell, and invasion, neurovascular and lymphatic invasion, and invasion of vessel membrane.
6 months later, patient develops cervical lymphadenopathy. How does cancer spread to lymph nodes?
Spread by amplification. Sorry, amplification and
I think she left. Dr. Abdurrahman, are you ready to continue this station?
Yes.
So go ahead, please.
I think last question I will answer. Yes? That is
yes. Yes, yes.
Okay. By embolization and permeation, yes. Also, lymph node perimeter will produce vascular endothelial growth factor C. This will cause vascular expansion and new vessel formation. This will and in the lymph node, in the perimeter tumor and in the sentinel near sentinel lymph node drain, in the draining sentinel lymph node, so will enhance metastasis.
Excellent.
Adjust your answer. انا مش عايزها كده يا احمد. انا عايزك تقعد بطريقه افضل من كده. انت you answered it correct but you will miss professionalism marks by this way.
I'll
So
try again.
examiner will find you that you are keeping information in your mind and you are hardly expressing them. This will be very bad. This is
Okay.
why we told you need practice on knowledge part like skills. I think people who failed in knowledge part, they told me after exam, it exactly like the mock. طب why you failed? Because of this way. Because of this way. So you can tell we have two different ways, permeation and mobilization. The mechanism of that malignant tumor will release growth factors which induce lymphatic vessels expansion or named lymphoangiogenesis in the primary tumors and also in the draining central lymph nodes. Only that. Okay, يلا سوزان.
Thank you.
Question number 3. Suzanne, your voice. Okay, I will read the question. Excision done but not enough. What you will do? Excision done for the lymph node but not enough. What you will do?
I will exercise or microsurgery.
Could you repeat your answer again in a proper way?
Mohs microsurgery. I will do Mohs microsurgery.
There are no other modalities. This is the only answer for this question.
No, excision, and until safety margin.
Yes, 3 excision or wider excision with frozen section or Mohs microsurgery. Give full answer and don't be hesitated while you are answering the questions, okay?
Okay, thank you.
Okay, what are the advantages of frozen section?
It is simple and quick and rapid performance. Cheap.
Sorry,
and
Suzanne. أنا آسف جدا. Sorry. Before this question, you have another question asked excision done but enough. يعني the question asked by another way. عشان سوزان لأن هم بيلخبطوا فيه. It's written for you that cytology done for the patient but deemed to be inappropriate. Why? The question is asked by this way. Cytology done before excision, Suzanne. Cytology done for this patient but deemed to be inappropriate. Why?
I think needs wide depth will not effective. I think it needs more wider excision.
My question again. This patient is a question about mechanism of lymph node. So patient has lymphadenopathy. Then I ask you what you will do for lymph node. You will tell find needle aspiration cytology. Find needle aspiration cytology. So the next question for that will tell you that cytology deemed to be inappropriate. Why?
Frankly, I don't know.
Yasmin, please answer.
Can clarify the question? Cytology not
ask it by this way. The question asked by شفت انا سالت السؤال انا عارف كويس جدا ان هم هيقفوا عنده. They stuck in this question. Again, patient with lymphadenopathy. Patient with lymphadenopathy. Find needle aspiration cytology done for the patient. Next question for the patient, cytology deemed to be inappropriate. Why?
because cytology only cells clarify only cells, not the tissue surrounding tissue, or inadequate cytology.
Sample may be inadequate. Lack of differentiation also has not produced the definitive result. Also because of poor technique. Poor technique can be also one of them. Lack of differentiation, improper technique or poor technique, and the sample inadequate. This what? Rajat Sharma. Welcome. Rajat examined in Cairo. خليك معنا يا Rajat. Yes. He was examined in Cairo and he's waiting his result. It's amazing. Join us. يلا.
What are the advantages of frozen section?
Rapid and intraoperative result. Report coming in intra.
simple and quick performing of quick getting of report in the interoperative.
Yes, same answer repeated by you. Clear. Excellent. What other alternatives to frozen section?
Microsurgery.
Yes. After excision and grafting, graft became infected and sloughed. Swab shows MRSA. What will you do?
If patient admission will be isolated and call or inform the isolated team and call the nurse, inform the nurse staff and do protection by the washing hand and give IV and IV antibiotic and isolation patient. If not admitted, can be given orally antibiotic.
So if he is admitted, you will just isolate and you will not give any medication? Yasmin,
What?
you will just isolate the patient and you will
But
not
this is
give any medication?
Dr. Yasmin,
نعم.
if you will
نعم.
go to your exam by this concentration, you will miss many station. انت ركز دلوقتي كانك في امتحان. ركز في السؤال. على فكره اسمعي، اللي بيضيع في الامتحان ده مش واحد بيذاكر وواحد مش بيذاكر. نو مش كده خالص. This exam not by you are studying more or less. You are smart enough to understand the question, to skip from the question, to answer it, to communicate with the examiner. مش بالطريقه دي. يلا كملي. Ask her, Susanna, again. Ask her again, Susanna.
After excision, the graft and grafting, the graft became infected and sloughed. Swab shows MRSA. What will you do? You told that you will isolate the patient. Just you will keep him in isolation. This is his management?
No. We'll manage the patient. The graft will become the debridement and do dressing after.
What else?
After antibiotic.
Which antibiotic will you give?
And
which IV antibiotics will you give?
I will give according to the microbiologist and I give vancomycin-based drug.
Please give the full answer from the beginning. Not all the examiners will ask you one by one. You will lose mark like this, and don't be hesitated. Define granulation tissue.
Granulation tissue is the have the have fibroblast and loose connective tissue and new blood vessel and scattered inflammatory cell. And this forming the tissue that need healing, want healing.
What is the fate of granulation tissue?
Fate after remodeling and scar formation.
Could you repeat your answer again?
The granulation tissue is chronic wound healing after the remodeling and the stage of the wound healing, the remodeling and the scar formation.
You know the answer, but you give it in a very non-organized way. That will give a very bad impression about you to the examiner. You know everything, but you need to organize the answers, and that will never be done except with too much practice. You have to practice every day and night, okay?
Okay.
The fate of the granulation tissue is remodeling. Then 2 to 3 weeks, scarring or fibrous scar will be formed. Okay? You know, I know that you know, but the examiner will not make an effort to know that you know. He needs the answer clearly, okay? Dr. Salah, do you want to give any more questions or you want to add any comment for them?
No, this station, by the way, came in Cairo on last March. About forearm ulcer, it was one of the new station came in UK. It didn't came in Cairo. So you will find it in new station. It's a combination between the our book, the updated station, and the basal cell carcinoma, the old one. So MRSA management is very important. MRSA management is very important to keep them. Just only their performance needs to be more confident when answering. I will not accept any level to go to the exam by this way. If with practice anyone will be hesitated in his answer, don't go for the exam. Exam will discover it. It will be difficult. So what should we do? Practice. انتوا عارفين يعني I wanted to tell you very important to experience about knowledge part. احنا جات لنا النهارده نتيجه الاء يا سوزان جايبه كام في النولج؟ 152. الاء from Dubai, from Oman, Edinburgh people. She scored how much? She scored how much in knowledge part? 152. I talked to Shnoda today about again Oman exam. It was difficult to Shnoda why people failed in knowledge part. He told me all from the MOOC. Really, I listened for this MOOC all from the MOOC. Salah. I don't know why these people still they can't answer because of practice. You think I should practice in the skills part only? No. Try to, يعني this is very nice, Dr. Yasmin, to start to raise your hand and take a station, even you are not well prepared. Anyone. I am thanking all people who are sharing. ما تفكرش ان انا بزعل انا متضايق منك. لا انا زعلان عشانك. يعني if I am shouting with anyone in life, this means what? You are my brothers and sister, and I know how is evaluation. So I give you your weakness. I give you now before exam your weakness. Improve them. This girl, she scored in Oman exam 152 from 160. From where? She told me MOOCs only. She studied MOOCs only. So still you are suffering in expressing your ideas. Okay? يلا سوزان اللي بعده عشان بس نخلص.
Okay, Dr. Saroj and Dr. Pruma.
I didn't take full station, Dr. Suzanne. I think I used station 5.
نص باخد نص لجنه. خليك مش مشكله. سيبي لو عايز حاجه ثانيه كملي معايا مفيش مشكله.
Okay. We have also Dr. Pruma.
عبد الرحمن, they will give a station for another new two, and within remaining any station at the end you can join. You can join again.
Actually, he picked a station chosen by two before him.
No, I didn't take.
علي ما خدش هو ايه في بطل افتراء ايه في ايه.
No, he picked number 5, but Dr. Saroj and Dr. Pruma picked it before him.
No, I have a comment for Susanism. The layer of will affect.
Okay.
I'm vascular surgery. I'm in Egypt now. It's Zamal Misriya. So I know Susanism will affect whole layer, not
all vascular people they see this message and told all layers. But
I don't know. Maybe different schools. I don't know.
I don't know also a lot, but is the difference between pseudoaneurysm and aneurysm? Pseudoaneurysm is this named pseudo. Why? What is the meaning of pseudo? Not true. Yeah, not true. Not true. So not all layers. يعني biologic.
Okay, no problem.
Okay, Dr. Saroj, are you ready?
Yes, ma'am.
Dr. Pruma, are you with me?
Yes, for Barca, you should keep all information about isolation, contact the infectious community consultant, everything related to basal cell carcinoma about MRSA should be mentioned. Okay. يلا يا سوزان.
Okay, I'll start with Dr. Sarosh. Dr. Pruma, keep ready.
Okay.
اقول لك على حاجه صعب كمان يا سعيد. in MRSA in procedure in OR listing the MRSA patient will ask you after finishing of the operation what you will do. You will tell the fumigation. What else? He asked you what else. When asking you what else, you will tell everything about MRSA. I will do screening, isolation, contacting, management of the patient carrier. يعني for management of MRSA can be asked here, can be asked in basal cell carcinoma, can be asked in OR listing. تمام كده؟ So keep everything about MRSA. يلا next. Start us معلش أنا آسف.
Our same the young patient has pain, tenderness, redness, and all features of a thigh abscess. Actually, this station doesn't come as a separate station, but because we want you to concentrate on every single info in this station, we keep it as a single one. So, Dr. Sarosh, what is abscess?
Abscess is a painful localized collection of pus, usually caused by bacteria.
How does it differ from cellulitis?
Abscess is usually caused by Staphylococcus aureus, and the cellulitis is caused by the group A Staphylococci. And where abscess is localized and cellulitis is diffused, and necrosis have a central zone of necrosis where the cellulitis have a diffuse necrosis, and the pus in the abscess will be rapid formation and thick and yellow, and in case of cellulitis the pus will be slow forming, thin, and contain RBC.
What are the constituents of pus?
Neutrophil, a dead microorganism, pseudodermis.
Excellent. How do you know which organism is the cause without any test?
By seeing the color of the pus, in which Staphylococcus aureus there will be yellow color, and in Pseudomonas there will be green color of pus. Sorry, yes, green color of pus, and in Acetonomyces there will be silver granules.
What are the causes of abscess?
Bacterial and non-bacterial.
Sorry?
Bacterial and non-bacterial.
Okay, thank you, Dr. Sarosh. Dr. Pruma, could you continue with me?
Yes.
What are the causes of non-bacterial abscess?
There is viral causes, fungal or parasitic cause for abscess.
How do you treat an abscess?
By incision and drainage.
What else?
And packing of the abscess and regular dressing, and if there is any signs of spreading of an abscess or cellulitis with IV antibiotic.
Excellent. When is antibiotic required for abscess?
If the abscess is not localized, if there is any signs of cellulitis, or if the cavity is not left open to free drainage.
Which stain is used for tubercular bacilli?
Zilnilson staining.
What else?
Stain.
What else rather than Zilnilson stain?
I don't know.
Foramin stain mentioned in tuberculosis station. And we did it, I think, in the poster. Okay, Dr. Salah, I finished my questions for Dr. Sarosh and Dr. Pruma. Do you have any more questions for them?
You know, this came as a separate station in Dubai also. In December, last December.
Very nice. Anyway, it's a gift. Easy, straightforward station.
And the UK, yeah, case came before in UK. I know. Right. With me, could you tell me the mechanism of fever in abscess? How fever will occur in abscess? Mechanism of fever in abscess?
Dr. Pruma.
Yes, fever is caused due to the substance called pyrogens. such as tumor necrosis factor interleukin-6, which causes stimulate prostaglandin synthesis in the vascular and perivascular cells of the hypothalamus.
How you know this answer? We discussed it before.
It's in the notes, sir, in
Yes.
news stations note.
Yes, it's written in the notes before since long time. Type. Next
Yes.
question. What is the I will share for you the mechanism of fever with microorganisms. I have the next picture one with me. Here for you now. I want you to write your answer. I want you to write your answer also in the group, okay?
Okay.
This is the first question. What about antibiotic?
Sorry?
هقول لك السؤال ازاي بالظبط. What is the rationale of giving antibiotic in abscess? What is the rationale? The question asked, what is the rationale of giving antibiotic in abscess?
I don't know.
Prevent the spread of the abscess.
What?
To prevent the spread of the abscess.
Okay. What is the rationale of giving antibiotic in abscess? It means when you will give antibiotic, it is the next question. When you will give antibiotic for the abscess, how to give? Listen. Very important to first. You will start first taking first before drainage. You will take a swab, and you will do drainage first if the abscess is localized, not without no evidence of cellulitis, and it is localized, fluctuating. I will go for drainage of it. Then I will take a swab, and I will give empirical antibiotic after discussion with microbiologist, and according to the question, I will change that. تمام كده؟ Has noise background. مين عنده سوزان؟
I don't know. I searched actually. I didn't find any mic swinging except yours.
أنا؟ Okay. Next question.
أدور ممكن العيال جابوا كلب.
Okay. What is the specific stain for the staff? Asking about organism like Suzanne. Ask it now. What is the stain for the staff? أنا بربي كلاب. أنا مش عارف أربي العيال. أروح أربي كلاب. Gram stain. Excellent. Rajat, open the mic for Rajat. Raise your hand. Is this your station? Rajat, your station? Tell me about any new question. يعني this station came in. Raise your hand Rajat. يلا. خدوا الراجل ده خبرة جدا. خدوا بقى هيقول لكم خدوا بقى هيقول لكم يلا. So Rajat.
Good evening, Dr. Sala. Good evening, Dr. Susan.
You missed our lives. This is why you joined. You are waiting your result and you will pass for sure 100%. So why you are joining us? You want to enjoy?
I don't know whether I will pass or not.
Okay. Is this station came for you?
Yes, Dr. Sala.
Tell me from A to Z how this station came and what you...
Yeah, it starts from the question number 1. What are the differences between abscess and cellulitis? And the second question is, what is the rationale of giving antibiotics in abscess? How fever is caused in abscess? Question number 3. Question number 4. They have given one scenario in which granuloma is formed, and they asked, can you tell me the what is it? So they want the full answer, Mycobacterium tuberculosis. And then it went to the stain for tuberculosis. Then next question is, why lymph nodes are enlarged in the abscess? And the last question in this case is, yes, about the lymph node structure, that is reactive follicular hyperplasia, which occurred in the cortex and medulla. That's it.
Okay, this question will be discussed already. Will be discussed, inshallah. And he's asking also the third question I want to ask you. It's written why there is enlargement of lymph node. Why there is enlargement of lymph node? Because draining area abscess on cellular level basis. Okay. This is also the second question. What two common malignancies of cervical? Now, this is another question. So I think all the questions asked now. Why fever and why enlarged lymph node? How you answer the question of enlarged lymph node?
So I told about the follicular hyperplasia in the cortex region. That's why the lymph nodes are enlarged. I wrote the answer for Dr. Maria. I told her that I gave that answer, but he was not accepting the answer.
Because he wants in the immunity and the cellular level. Okay, so I will search for this answer. This is the only question. This is the only question.
So I told inflamed lymph nodes are often enlarged because of the hyperplasia of the lymphoid follicles and increased number of lymphocytes and macrophages.
He wants according to the cellular immunity or cellular level, as I
Yes,
hear.
maybe.
Okay. I think
that's it.
was a question like our book.
Yes, sir. Yes, sir.
It was separate station.
It was separate station.
Okay.
In pathology, two stations came, this abscess and gastric cancer.
Okay, Dr. Suzanne, yalla, next.
Okay, Dr. MMA. I don't know who is MMA, maybe middle meningeal artery. I don't know. And Dr. Adnan, please raise your hand so I can recognize you.
You should keep him. This is Marwan. You should keep abbreviation.
السلام عليكم.
وعليكم السلام. Dr. Marwan, are you ready?
Yes, I'm ready.
Dr. Adnan, please unmute your mic. He will be next to Dr. Marwan. A patient with a left iliac fossa pain and peritonism, Hartmann separation done. Histopathology report showed diverticulitis and endometriosis. What is the lining of the colon?
Simple columnar epithelium.
Are you asking me?
Simple columnar epithelium.
Thank you. What are diverticular disease, diverticulitis, and endometriosis? Define each of them.
Yes, diverticular disease is diverticular with symptom. Diverticulitis is an infection.
What is diverticular?
Yes, that is outwatching or diverticulum.
So give it a full definition.
Yes,
please.
Yes. Diverticulitis is inflammation of diverticular, and endometriosis is presence of endometrial tissue outside the uterus.
What is the pathology of diverticulitis?
Pathology of diverticulitis is inflammation of is infection or inflammation of diverticula, which is the outwatch mainly in the sigmoid.
And what is the pathophysiology of diverticulosis?
Yes, the pathology of diverticulitis is infection or inflammation of diverticula.
Pathophysiology of diverticulosis.
Pathophysiology of diverticulosis is due to outwatching in
it is either congenital or acquired,
yes.
And it occurs due to the high pressure against the weak points of the bowel in between the tiny coli. Why endometriosis cause pain?
Yes, maybe due to bleeding, intrapelvic bleeding, or due to peritoneal adhesion.
How do endometriosis get into the colon?
Yes, there is many theory about this issue. Maybe retrograde flow of menstrual endometrium,
or maybe distant metastasis through the blood or lymphatic tissue, due to blood vessel or lymphatic system, or maybe direct from colonic epithelium during embryonic development, and also maybe from stem cell with from the bone marrow, and lastly differentiated into endometrial tissue.
Tissue samples from the operation shows neutrophils. What does this mean?
Infection.
Okay, thank you, Dr. Marwan. Dr. Adnan, please continue with me.
Okay.
How do neutrophils arrive here?
Neutrophils first roll along the blood vessel, then become activated and adhere to the endothelium, which then transmigrate across the endothelium. And after that, it pierce the basement membrane and migrate toward the chemoattractant agents.
Excellent. How much is neutrophils' lifespan?
3 to 5 days.
What is abscess?
Abscess, it's a focal collection of pus, which is that may be caused by seeding of biogenic organisms into a tissue or by secondary infection of a necrotic foci.
What are the contents inside an abscess?
Contents inside the abscess, it will be dead bacteria and living bacteria, neutrophils, cellular debris, and liquefied tissues.
How to manage intra-abdominal collection?
By open drainage and or image-guided aspiration.
Okay, I finished my question regarding this question. Dr. Salah, do you have any comment or you want to add anything further?
Yes, we have update for this station, Dr. Suzanne.
Very nice, waiting for that.
طيب ارجعي كده للجنة كده. I don't know, I put where. أنا شيرتوها قبل كده الانdometriosis دي. This came in UK in October. Came in UK in October. And we have, yes, الحمد لله لقيتها. الحمد لله لقيتها. ده احنا معانا ابديتس كتير فيها يا سوزان. شكلك كنت مشغولة بحاجة معينة ما كنتش فاضية ترتبي المكات دي يا سوزان.
No, actually, as I hear that you told not to add the updates and we will discuss them during the live. That's what I get. And I was busy preparing the file for part A. You know that. I was not playing.
انتوا هنكتم وضعفتم مع عظمكم وراخي وما عدتوش نافعين. نشوف ناس تانية.
That's great. Can I go now? I'm ready.
طيب ماشي. المشكله انت عارف ما اعرفش استنى عنك يعني دي المصيبه يعني ما هي دي المصيبه. هو لو نعرف نخلص منك كنا خلصنا بس مش عارفين. طيب this station by the way it has many updates and the 100 this station came in UK and came انا عارف لكم فين كمان came in Kuala Lumpur also came in Kuala Lumpur as I remember. طيب look now for this station all of the station is different. Okay. Diverticular disease and endometriosis. STEM 59 years old, perforation in the right iliac managed by Hartmann and stomach formed. Blood pressure is low, pulse tachycardic, fever, and the blood pressure, and what is else? Breathing. Everything is low, tachycardia, respiration is rapid, and the patient febrile. Diagnosis. Septic shock. How is this endometriosis? Yes, this station going by this way. It started by this way. So your diagnosis: septic shock, lining of mucosa, simple columnar epithelium. What is the layer below mucosa? Submucosa. What is the contents of submucosa? Blood vessels, arcade, connective tissue, nerves. Pelvic abscess contents was like any content of any abscess. dead and live microorganisms neutrophils. Okay, يعني so the content of the abscess it will be dead and live microorganisms plus neutrophils. Causes of abscess in this patient because of perforation. Why in pelvic, the most dependent area? Inflammatory cells in abscess, neutrophils. What is the content of cytoplasm of neutrophils? Lysosomal enzyme leukocidin. Theories of endometriosis and why this patient has endometriosis like the remaining of the station. انا افتكرت مين اللي بعت لي اللجنه دي. This station came for me from Ahmed Zalat in Kuala Lumpur first. In Kuala Lumpur, month 8 or month 9. Month 9. It was in month 9. هو نجح في شهر 9. Yes, it was in September. After that, this station came in UK on October. This station, they like it. Even came in Cairo since long time. So please keep this updates. The station started by this way. He told me, by the way, he buzzed. Ahmed Zarat, he buzzed, and he told me the station, it has many new questions, but anybody can answer from his knowledge. If he has knowledge. And if you see the station is going smoothly. So صراحة it's very easy station. ده انتوا معاكم الستيشن بقالها 5-6 سنين وبتدخلوا تلخبطوا فيها وحافظينها وتدخلوا تلخبطوا فيها. ما بالك لما يسألك أسئلة جديدة. You have the stations now, you have 2 or 3 years, and still when asking you are still confused. So what about any new questions? This came for the first time updates in Kuala Lumpur exam, September exam, then repeated on UK month 10. So keep this station. It's very, very important. Okay, clear? وقولي يا دكتوره وداد بالله عليك ازاي اخلص من سوزان؟ بالله عليك اديني نصيحه كده لما تيجي خميس مشيت تعرفيني ازاي اخلص منها بطريقه كويسه شيك يعني عشان ما يبانش ان انا ايه ببيع زمايلي واصحابي اللي وقفوا جنبي يعني. عايز كده الناس تقول علي ما تقولش اصل انا قلت لكم هنفصل ويا تختاروا شنودة وصلاح ولا سوزان وماريا، هتروحوا سوزان وماريا. انا فاهم، سيبك بقى من الكلام ده، انا هتروحوا لها، هم اللي ابديتد وهم اللي معاهم كل حاجه يعني. يلا.
لا يعني هناخد معانا دكتور شنودة يا دكتور صلاح، ما تشيلش هم.
ايوه صح صح. لا شنودة وفي، شنودة وفي.
لا بس حضرتك عارف الحتة الويك بوينت واحنا هنلعب عليها.
صح. ايوه كمل. هاخد محمد رضا او محترم وانجليزي. يلا ما ناخد بريك، ناخد بريك ولا ايه رايك؟ احنا كام لجنه؟ فاضل كام لجنه؟
فينيش 6 وباقي 5.
طب ما تدينا بريك بالله عليك كده وخليك انت الحل البريك كده.
Okay.
يلا بريك for 10 minutes.
Okay, so the next will be Dr. Ahmed Ali, Dr. Priyanka, Rami Salama, Hadir, Aya, Munawar, Bella, Wafa, Nabila, Sarah, Said, Hiba, and Bainza. Please be ready for the next part of our session.
ماشي يا دكتور منصور، بس ناخد بريك كده، ناخد بريك 10 minutes only. يلا. Okay, regarding of the question about why endometriosis in this patient, he's asking about the theories. He's asking about the theories. يعني the started why endometriosis, he means what is the theories يعني. Okay, this is the first question. Regarding of the question of abscess, what is the rationale of antibiotic? انت راكز سؤال في الاجابه دي، انا جبتها من دماغي يعني اعتقد accepted. What is the rationale of giving antibiotic in abscess? You will tell if abscess is localized and fluctuating and needs to be drained. It will be drained. After that, I will take a swab, and after discussion with microbiologist, I will give empirical antibiotic till the culture and sensitivity came. صح كده ولا في حاجة تانية تتقال؟
Well, that was the answer we are giving in the abscess station in procedure.
Yes, stations and accepted. Okay. Other question about lymphadenopathy in abscess, I sent already in the notes group the mechanism how lymphadenopathy happened, about obstruction and about inflammatory and cytokines process which cause lymphadenitis or lymphadenopathy. Okay. يلا يا سوزان start.
Okay, Dr. Ahmed Ali will start with you.
Okay.
This time is a 76-year-old female referred from temporal artery biopsy, presented with headache, scalp tenderness, upper limb stiffness, and transient loss of vision in one eye. The first question, why biopsy taken in this patient?
biopsy taken of this patient to diagnose giant cell arthritis?
You are asking me?
No, I'm answering.
What is giant cell arthritis?
Giant cell arthritis is inflammatory arthritis affecting the large and small blood vessels in the head and neck, most commonly branches of external carotid artery.
It is granulomatous inflammatory disease. You have to mention granulomatous. What are the histological findings on biopsy for giant cell arthritis?
Multinucleated cells composed of macrophages infiltrated by lymphocytes and plasma cells.
What is the cause for loss of vision in a patient with temporal arthritis?
Involving of the ophthalmic artery, which gives the central retinal branch, which is end artery, causing loss of vision.
Patient simple blood test could be used in diagnosis of temporal arthritis.
ESR.
What else?
CRP.
How is this treated? Mention doses of the medication you will use.
Treated by oral prednisolone, 60 milligram OD for 2 years.
Thank you, Dr. Ahmed. Dr. Priyanka.
Yes, doctor.
A patient came back a year later with a fracture neck of femur. What are the possible risk factors for pathological fracture in this patient?
Most likely, this is due to AVN, osteoporosis, or myopathy.
What do you mean by AVN? Don't give abbreviation, please.
Sorry, avascular necrosis.
What other local risk factors for pathological fracture in elderly?
Steroid therapy and postmenopausal female in case. Hello.
What is pathology of osteoporosis?
Basically, histologically, the means there is a normal architectural bone, but there is a decreased density. And also in post-menopausal osteoporosis, there is increased osteoclastic activity, which affects mainly the bone, which has increased bone surface area like cancellous bone, and there is a trabecular plates involvement, which are perforated, thin, and lose their interconnections, leads to progressive microfractures and eventual vertebral collapse.
What are the perioperative concerns in such a patient?
Preoperative concerns is actually they can lead to collapse or the fracture.
Sorry?
What do you mean by preoperative concern?
You have a
didn't
patient with a
get
fractured
that.
neck of femur. How you are going to manage?
Yeah.
Surgically, no? So what are the
surgically.
perioperative
Yeah,
concerns?
Yeah, actually recurrence and AVN.
In this
Recurrence of
patient
fracture.
with osteoporosis or long-term steroids, these are the only concerns?
You have patient taking steroid and he has fractured neck of femur. What you will do pre-op for this patient? What your concern is?
You are managing the patient as a whole.
I will fix
Only the fracture.
I will fix the fracture first. Then my preoperative concerns will be the risk factors for the further maybe lead to AVN or maybe further pathological fractures like he's on steroids.
So as she is on steroids, you will stop the steroids and take her to the ward, no?
No, I will the main preoperative concern is Addisonian crisis, sorry.
we have many things pre-operative. This patient is taking steroid. So number one, additional crisis. Number two,
Yes.
electrolyte disturbance, maybe because of patient is taking steroid, maybe patient has electrolyte disturbance. Okay.
Okay.
After surgery for the fracture, she developed confusion, shortness of breath, and petechial rash. What is your diagnosis?
Fat embolism.
What is the pathogenesis of fat embolism?
Usually in fat embolism, what happens, there is a blockage of the micro arteries, so that leads to the fat embolism, microvasculature blockage.
Blockage by what?
Blockage by the fat.
Coming from where?
From the long bones.
So give full answer, please.
Oh, sorry.
Dr. Ahmed, what is osteoid?
Osteoid is a protein protein formed by the osteoblast, help in bone formation.
Dr. Priyanka, what is the risk factor for osteomalacia?
Vitamin D deficiency, calcium deficiency.
You want to add anything?
Nutritional deficiency.
What nutritional deficiency do you mean?
Like iodine deficiency.
Sorry?
Calcium deficiency.
So it is calcium deficiency. Whether
Yes.
it is nutritional, iatrogenic due to medication, or whatever. What's protein?
And other one is the genetic in which there is a receptors are absent, maybe the cause.
Okay. Dr. Ahmed, what is the protein deposition in this case?
It's amyloid AA.
Dr. Priyanka, why it couldn't be removed from the body, the amyloid?
Because our kidneys are unable to infiltrate the beta-2 microglobulin.
Could you repeat
And
your
there is
answer,
absence
please?
of the enzyme.
I didn't get your answer.
In kidney, the beta-2 microglobulin, our kidneys are unable to infiltrate. And there is also absence of enzymes in our body, so they cannot be metabolized.
So first, absence of the enzymes, then the excretion. Am I right?
Okay.
It will
Yes.
be broken down first, then it will be excreted. So start by the
Yes.
first step.
Okay.
Okay, Dr. Ahmed Ali, how to do ESR?
Take a blood sample from the patient and put it into a vertical test tube. Then the RBCs will clump together down by centrifusion, and the above supernatant fluid in the top of the tube will be measured after 1 hour and 2 hours.
Okay, I finished my questions in this station. Dr. Salah, do you have any comment or you want to add any questions?
Priyanka, you didn't prepare this station. You didn't review the notes group because all the questions asked by Dr. Suzanne in notes group. So for sure, you didn't review the notes group. Just you keep the book, and the book is not updated. So why temporal artery biopsy is indicated to identify temporal or joint arthritis. The pathology of joint arthritis, inflammatory arthritis with fibrinoid necrosis, characteristic histological appearance is lymphocyte, plasma cell, and histocyte cell infiltrate. Type. Other question. What other bone disease can predispose to fracture in elderly?
These are skeletal metastasis and Paget's disease and multiple myeloma, rickets, osteomalacia, osteogenesis imperfecta, and radiotherapy.
You answered all, but you give only 3 from 4. So osteomalacia 1 mark, Paget disease another mark, hyperparathyroidism mark, neoplasm primary or metastatic. This question by 4 marks. Describe pathology of osteoporosis Bone will be normal in type and mineralization, but deficiency in overall
Density.
overall or density, in overall volume or density. Another question asked for you: what is the risk factors relevant to development of osteoporosis in this patient?
In this patient, steroid therapy and postmenopausal.
Okay, age, postmenopausal, steroid therapy. What else? Female. Female. So you have another 4 marks from 20 in 4 words: age, female, postmenopausal, and steroid. Regarding the consideration, steroid cover and supplementation to avoid relapse of arthritis and to avoid adrenal or Addisonian crisis. Okay. Type. Still, she asked you about how to do ECR. Agree. What is the factor of osteoporosis in this patient? Steroid or the age, female. I wrote in the group plus postmenopausal. I will add it because this is a postmenopausal. Menopausal. Okay. What else? What other question? She asked how to do ECR. Why amyloid not removed from the body? If you still didn't know the answer, means you are away from the study since long time. Priyanka, I don't know why. So this in notes group since long time. Amyloid not removed from the body because it's strong. Okay, protein. What else? Osteomalacia, because of risk factor of osteomalacia, steroid malabsorption, renal failure, immobility, vitamin D deficiency, vitamin C deficiency, calcium deficiency, pathogenesis of fat embolism. He's waiting this word, debut derived fat. This will arise. This is the cause of fat embolism. This will be arised or will be taken by disruption of the debut fat because of trauma. Osteoid definition already done. Pathological changes in osteoporosis. You will tell about that. Histologically, bone will be normal but decreased in density. The mechanism behind it, you have 3 mechanisms: inadequate peak bone mass, excessive bone resorption because of osteoclast, inadequate formation of new bone formation during the bone turnover because defect in osteoblast. All of this in notes group, by the way. تمام كده؟ يلا سوزان next.
Okay, Dr. Aya and Dr. Hadir.
Yes, Dr. Susan.
Dr. Rami.
Question number 7 already shared with Dr. Haifa in the notes group. Osteoporosis, 4 things. Old age, female, osteoporosis, and steroid. Postmenopausal, old, female, and steroid. ما هو موجود في نص الجروب يا شباب. يلا.
Okay, Dr. Rami will be first, then Dr. Hadir, then Dr. Aya. Dr. Rami, are you ready?
Yes, hello. How are you, Dr. Suzanne?
Fine, how are you?
Dr. Mark in notes group. The word of fat, debut fat. يا شباب ما هو I just shared it. I want to go for this group. You will find all your answers. أنا ما بجاوبش كده verbally. The answer already in the group. هو في شباب في ناس. يلا.
A 78-year-old man with black discoloration of his great toe. This station discussed already in the posting group. What is the pathology with this presentation, Dr. Rami?
Gangrene.
What are the types of cell death? Do you know?
Necrosis and apoptosis.
Mention 4 differences between necrosis and apoptosis.
Necrosis is a pathological condition in which there is unregulated cell death, in which there is a swollen cell with the disruption of the plasma membrane. The nuclear content are digested in this process, and the cell content also digested by the enzymes of lysosomes. And there is adjacent inflammation in the tissue surrounding the necrotic area. While the apoptosis is a process of programmed cell death in which there is a shrunken cell size. The nucleus may be divided into nucleosome bodies, and the cellular content may be divided into apoptotic bodies, and there is no surrounding inflammation in this apoptosis.
Mention 4 differences between wet and dry gangrene.
The dry gangrene site usually occurs in the limbs, and usually occurs due to arterial occlusion. The affected organ is dry, black, and shrunken. There is no putrefaction. There is a line of demarcation usually, and as regards the bacteria, there is no bacteria, cannot survive, and as regards the prognosis, is a good prognosis or better prognosis. As regards the wet gangrene, usually occurs in the intestine, usually occurs due to venous occlusion, and the affected organ is moist, swollen, and there is a putrefaction in it due to stuffing with blood. And as regards the prognosis, not a good prognosis, usually due to associated septicemia or toxemia.
Gangrene surrounding area shows redness. What is the pathological process?
Reactive hyperemia or vasodilation.
Post-hypoxic vasodilation. Okay, thank you, Dr. Rami. Dr. Hadir, are you ready?
Yes.
What are the pathological cells present in an atheroma?
Foam cells.
Apart from hypertension, diabetes, and male sex, what are the other 3 major risk factors for atherosclerosis?
Smoking, family history, hyperlipidemia.
And age also could be considered as a risk factor. Sorry. Which size and type of vessels are affected by atherosclerosis?
Medium and large size vessels.
Patient shows X-ray with pleural plaques. What are pleural plaques?
They are collagen deposition and fibrosis with or without calcification.
Yes, deposits of dense collagen. What's their significance?
There are chronic asbestos exposure, which increases the risk of bronchogenic cancer and mesothelioma.
Mention classification of lung cancer.
Squamous cell carcinoma and mesothelioma and basal cell carcinoma.
You are asking me?
Now answering.
It is either a small cell lung cancer or non-small cell lung cancer. What are the non-small cell lung cancer?
Non-small lung cancer are squamous cell carcinoma and basal cell carcinoma and mesothelioma.
Adenocarcinoma, squamous cell carcinoma, and large cell cancer.
Okay.
Order lung cancer types according to prognosis from best to worst.
Best, the worst is small cell cancer. Can we skip? I don't know.
Small cell lung cancer is the worst prognosis, then adenocarcinoma, then large cell cancer, and the best is squamous cell cancer. Okay, thank you, Dr. Hadir. Dr. Aya, are you ready to continue?
Yes.
Okay, he presented with metastasis, which was found poorly differentiated. How to identify the tissue of origin?
Immunohistochemistry.
If the tumor is epidermal growth factor positive, what chemotherapeutic agent is appropriate to be used?
Tyrosine kinase inhibitor.
Like what?
Imatinib.
Mention types of necrosis, do you know?
Coagulative, liquefactive, caseous, fibrinoid, fat, and gangrenes.
What is adenocarcinoma?
It's epithelial-like tumor with malignant transformation and the glandular button.
What is emphysema?
Abnormal persistent dilatation of airway, distal to terminal bronchiole, cause shortness of breath.
How does it occur?
Persistent inflammatory process cause destruction wall of the alveoli and cause its distension and permanent dilatation.
What is paraneoplastic syndrome?
It's a complex of symptom and sign, cannot be explained by local or distant metastasis or hormone secreted from cell primary endogenous to the tumor.
What hormones are related to lung cancer?
ACTH and EDH
Which
related.
type?
Small cell cancer, small cell lung cancer, ACTH and EDH hormone.
Okay.
And parathyroid hormone related peptide by squamous cell carcinoma.
What is tumor necrosis factor?
It's type of cytokine involved in systemic inflammation and acute phase reactant.
Pro-inflammatory cytokine produced by the macrophage causing high temperature, high inflammatory marker, anti-tumor effect.
Can you repeat it again, please?
Pro-inflammatory cytokine produced by the macrophages causing high temperature, high inflammatory markers, and anti-tumor effect.
Thank you.
Okay, Dr. Salah, I finished my question in this station. Do you have any more questions for Dr. Rami, Dr. Hadir, and Dr. Aya? Generally, your performance is great.
Great. And I think this station came long time, and all updates you asked already. Don't forget, it's combined between gangrene and lung carcinoma. Okay, lung cancer. The only question can be asked or can be added here regarding of paraneoplastic syndrome definition and what is the type of paraneoplastic syndrome happened with each type of lung cancer. I think this will be discussed in details in lung carcinoma, inshallah. Or you should keep them. Yalla, next.
Okay, thank you, Dr. Rami, Dr. Hadir, Dr. Aya, Dr. Munawar, Bella, Dr. Wafa, and Dr. Nabila. Are you here so I can unmute you? Okay, nobody of them raised his hand, so I will unmute Dr. Badreddin and Dr. Mansour. Dr. Badreddin and Dr. Mansour, please unmute your mics.
الو
Hello, Dr. Mansour, how are you?
السلام عليكم، شو اخبارك دكتور سوزان؟
عليكم السلام ورحمة الله.
Sorry, Fatma, she asked me pathogenesis of osteomalacia, not pathogenesis of osteomalacia, pathogenesis of osteoporosis. Not, but we didn't discuss about the factors of osteomalacia only, already discussed. ركزوا يا شباب في الأسئلة. اوكي دكتور فاطمة؟ يلا.
الو السلام عليكم.
عليكم السلام. Okay, Dr. Mansour will be first, then Dr. Badreddin. Dr. Mansour, are you ready?
ان شاء الله.
Your stain is a pendicular carcinoid detected incidentally 8 mm size invading mucosa and muscularis propria. What is carcinoid? Define it, please.
Carcinoid is a slow-growing endocrine malignancy or endocrine tumor, can be grow from the different parts of the human body.
Slow-growing neuroendocrine, not only endocrine. What
Yes,
is the...
endocrine, Dr. Susan.
Sorry, maybe I have it by mistake. Where is it most commonly found?
Most commonly found in the appendix and the ileum, small intestine. Also can be in bronchus, pancreas, rectum, but most likely in appendix and ileum.
What are the methods to diagnose carcinoid?
First, we can diagnose it as from the serum chromogranin A, also by urine 5-hydroxy and endonucleic acid, and by immunohistochemistry for the chromogranin B.
What does it release? Which hormone?
For the tumors growth from the midgut, most likely is serotonin or bradykinin. For the tumor raised from the foregut, most likely it's histamine, and also there is bradykinin and prostaglandins.
Substance B and tachykinin as well.
Yes.
Which cells are involved in this tumor?
The cells involved is enterochromaffin cells in the cryptofluorocarbon.
When does it become symptomatic and why?
Most likely it becomes symptomatic when there is a liver invasion, because the liver is the main organ to detoxify this material produced by the tumor.
Signs and symptoms of carcinoid spread?
Periodic abdominal pain and heart problem like valvular lesion, especially the tricuspid regurgitation, diarrhea, asthma-like bronchial constriction, and cutaneous flushing.
Excellent. Thank you, Dr. Mansour. Dr. Badruddin, are you ready?
Yes, I'm ready.
So continue, please. Most common metastatic site?
Liver, small chromosomal site.
What is immunohistochemistry?
Immunohistochemistry is this pathological finding. It will detecting. It will be positive. It is detecting chromogranin P.
How does it work?
Fast.
Dr. Mansour.
Yes, immunohistochemistry is depend on the introduce an antibody to the blood to detect introduce antigen to the blood to detect the antibody in the specimen, and this antigen is connected to fluorescent dye or enzymes that activated when the antibody antigen complex happen.
Excellent. You have to keep this, Dr. Badruddin, because this question could be asked in any of the stations of pathology. Continue, Dr. Badruddin. Procedure of immunohistochemistry and significance of procedure, I think answered by Dr. Mansour. Which specialty does it? The immunohistochemistry.
Really, I'm not reading more about the chromographing. I don't know. Only which I know it is diagnostic for this carcinoid tumor, but I don't know more about it.
So what specialty is it, Dr. Mansour?
It's pathology
Yes,
specialty.
It is a pathological test. What is the significance of immunohistochemistry in carcinoid? I think Dr. Badruddin mentioned 100 times that it is to identify the chromogranin B. Excellent. After surgery, Pseudomonas colitis was suspected. What are the signs and symptoms of pseudomembranous colitis, Dr. Badruddin?
Patient will present with abdominal pain and blood diarrhea.
Actually, it depends on the severity, but this is the common symptoms, yes. Only one test to detect pseudomembranous formed by Clostridia, pseudomembrane, sorry. How to detect the pseudomembranes itself?
Endoscopy?
Yes, colonoscopy. And if they ask about tests to detect the pseudomembranous colitis, ELISA could be used.
The toxin, yes. It's asking about the toxin.
Dr. Mansour, the patient presented with a liver lesion for which resection done and histopathology reports showed the granulomas with necrotic core containing adult helminth in T. robius vermicularis. What is Enteropus vermicularis?
It's type of helminthes of nematode family.
Dr. Badruddin, why this patient need regular iron supplement?
Patient will, I don't know.
Dr. Mansour, could you answer, please?
Yeah, I think there is two reasons. The first reason, because here they mentioned there is liver lesion or liver resection. And the second reason maybe because I heard that Enteropus vermicularis for one of the complication of it, it's malabsorption.
Excellent. What is the TNM classification of this tumor of carcinoma?
This is for me or for Dr. Badruddin?
Dr. Badruddin.
Really, I didn't find this one in the book or in the lecture. I didn't find this note.
If you listen to the previous mock, you will find it. Okay, answer, Dr. Mansour.
Can we, I didn't find, can we return to the stem, please? It's invading mucosa and muscularis propria. This is T2. And he didn't mention anything about lymph node and metastasis. So most likely T2 in XMX.
What is the management needed for this tumor with this stage?
Most likely, I'm sorry.
Dr. Badruddin.
This one, if less than 6 millimeter conservative.
You have the size, please. You have the size. It is written in the stem. Don't say if.
Surgical.
Which surgery will do?
Resection or anastomosis.
Yes, if it is in the right side of the colon, terminal ileum, or the appendix, we do usually right hemicolectomy and ileocolic anastomosis. Okay, I finished my questions, Dr. Salah. Do you have any more questions or any comment further?
All the updates, many of you, they told not in the book. Okay, what is the benefit of notes group? We shared it in notes group before. I don't know, if we'll add these updates in the book, it's distributed. So all the information with you, and as you know, our book is downloadable and printable. So I don't know, wallah, we are struggling in this. Can we update our book and everything between your hands and will be all all over the world, or better to keep it by this way? So better to keep in the notes group. And wallah, really, if you want me to update our book, I can book this information in the book. But listen, this book will be distributed all over the world, and for sure, exam will be more difficult. Appendicular carcinoma, like exactly, I have nothing to be added. All the new questions added by Dr. Suzanne about TNM classification. Just I shared it also on the group about the type of surgery you will go or not to go to surgery, appendectomy or right hemicolectomy according to the size. More than 2 centimeters, you will go for right hemicolectomy. Less than 1 centimeter, you will go for appendectomy. Between 1 and 2, according to the site. If it is at the tip, you will go for appendectomy. If it's at the base, you will go for right hemicolectomy. Yalla, Susan, next station. Nothing to be added.
Dr. Said or Said?
سعيد شحاتة.
Please unmute your mic, Dr. Said.
آخر حاجة اللي هي إيه؟ آخر حاجة اللي هي إيه؟
Sorry?
واحد بيقول لك الجزاوي جو فور نوتس جروب يا جزاوي، جو فور نوتس جروب. أنا هعمل لك منشن عليها. هعمل لك منشن عليها أهي هعمل لك منشن.
Dr. Said, are you ready?
Yes, I am with you.
Okay, so will be Dr. Said and Dr. Sarah.
سعيد شحاتة.
سعيد خلاص اوكي ولا تزعل. سعيد خليك سعيد على طول.
لو قالت لك انت يو ار اسكينج مي قول لها ايوه بسالك. يا سعيد طلع
كنت
كله
هعمل كده يا باشا.
ما تسيبهاش النهارده
يا باشا كنت هعمل كده على فكره. انت عرفت ازاي؟
لا هو لو عمل كده دكتور زكي هياخد لي حقي. خد راحتك يا دكتور سعيد.
ذكي ما عملتش حاجه.
بيتهيألي كده غلبان.
انا اللي مربي ذكي.
ونعم
طيب.
التربيه، وقت لما ربيه انا عرفت هو طالع كده ليه، ونعم التربيه.
25-year-old male underwent bilateral
sorry.
nephrectomy.
عبد الرحمن يا جزاوي. I mentioned for you the carcinoid, management of carcinoid. I mentioned for you in the notes group. You can find it. يلا next.
25-year-old male underwent bilateral nephrectomy. First question, on the light of the picture given, what's your diagnosis?
I think it's a polycystic kidney disease.
Don't tell I think, just answer straightforwardly, please.
Okay, it's polycystic kidney disease.
What is the mode of inheritance of polycystic kidney disease?
Yes, it is autosomal dominant due to mutation in two genes, polycystic kidney disease 1 and polycystic kidney disease 2.
What other organs could be affected as well?
It may be other organs like cystic, like liver and spleen and pancreas and ovary.
And lungs and the intestine as well.
Yes, lung and intestine, yes.
What complications of pathology is not seen in this picture?
Do you see, excuse me, what's the complication
of this pathology is not seen in this picture?
Yes, maybe systematic like hypertension, or renal failure, or infection, or severe pain.
What complications of pathology can lead to pain?
Yes, it is due to the weight leading to stretch of the renal capsule by the cyst, or maybe a dragging pain.
And could be due to infection or hemorrhage into the cyst.
Okay.
What are the causes of renal failure in polycystic kidney disease?
It is due to replacement of the normal kidney tissue by cyst, so it is become non-function with infection leading to chronic inflammation and irritation and scarring, followed by renal failure.
What is the type of fluid contained within the cysts?
It is transbacterial secretion.
What are pathological types of transplant rejections?
It is according to the time, hyperacute and accelerated acute and acute and chronic.
Thank you, Dr. Said. Dr. Sarah, shall you continue with me, please?
Yeah.
What are the types of matching required before transplant?
ABU compatibility and also human leukocyte antigen A, B, and DR.
Can an imperfectly matched kidney be transplanted?
Yes, after the checking the ABU compatibility and human leukocytes and also immunosuppressions.
It is not perfectly matched, so checked already. Could it be transplanted?
Yes, with immunosuppression.
How to prevent transplant rejection?
So by checking ABU compatibility and human leukocyte antigen and also providing patients with immunosuppression.
7 days after transplantation, patient develops swelling at the operative site with declining renal function. What do you think the cause is?
Acute rejection or infection.
4 months later, he came with CBD stone, fever, and sepsis. What is your diagnosis? Common bile duct stone, fever, and sepsis.
Obstructed common bile stones.
So what is the diagnosis?
Cholangitis.
Ascending cholangitis, yes. What is the management needed for this situation?
So starting the patients on IV antibiotics, and also with regards to when the patient is settled, then they can be organized for cholecystectomy as a semi-elective.
What do you mean by the patient is settled?
So when you have treated the sepsis with sepsis 6.
Could
then
you treat the sepsis while the obstruction is there?
Relieve the obstruction.
How?
By putting a stent.
How you would put this stent?
Sorry, pass.
ما تقولي RCP.
ARCP.
Yeah.
Endoscopic retrograde pancreatic cholangioscopy to remove the stone, and you can put a stent if needed. Dr. Saeed, are you here or you left? I think he left. He closed his mic. Okay, Dr. Sarah, continue. ARCP done, but he developed sepsis. What are the possible causes of bacterial infection in this patient?
Opportunistic infections. This is a transplanted patient with cytomegalovirus or Epstein-Barr virus.
Yes, and he is on immunohistochemistry for sure. Immunosuppressive medication.
Yeah.
What is the cause of CBD stone in this patient?
Immunosuppression.
Immunosuppression per se is not the cause.
And also presence of the polycystic kidney disease.
This patient has infection before. Okay, he might be dehydrated, and
Yes,
that causes,
yeah.
yes, and he was maybe in sepsis, for example, and that could be the cause of stasis and CBD stone formation. Cholecystectomy done and gallbladder sent for histopathological examination. What to look for in the specimen sent?
Not sure.
Like any pathological examination, you will look for the cell type.
Okay.
If
Cell
there is
type,
inflammation, infection type. If there is infection, you will see the type of infection. If there is any transformation of the or abnormal cells, you will see the grading of the cells and like that.
Margins and infiltration.
Yes, sure. Yes. Patient comes 6 years after transplant on immunosuppression with declined renal function. Biopsy shows lymphocystic infiltration with blast cells. What is your diagnosis?
Lymphoma.
Lymphoproliferative disease. What is not? Why is it not a rejection?
Because the biopsy shows there is a presence of blast cells.
How to treat post-transplant lymphoproliferative disorder?
Decrease immunosuppression, chemotherapy, and also anti-CD20 antibody treatment.
Yeah, Dr. Said, I think there is a problem with your mic. I tried to unmute you many times, but I failed. I don't know why. What are the causative factors for post-transplant lymphoproliferative disorder, Dr. Said?
It is usually viral infection due to decreased immunity and using immunosuppressive drugs like cytomegalovirus and Epstein-Barr virus.
Okay, that was the last question. Dr. Salah, do you have any comment or you want to add any question for them?
دكتورة هيفاء خليكي معايا. I open the mic for you. خليكي معايا ماشي؟
Okay.
سعيد.
يا باشا.
This station came in Dubai exam. Okay, exactly by this way. Okay, Dubai. Stem polycystic kidney disease. Anyhow diagnosed as polycystic kidney disease. What are the causes of renal failure in patient with polycystic kidney? Discussed already. Mode of inheritance discussed already. The fluid found inside the cyst discussed already. Pathological types of transplant rejection.
Yes.
يلا answer.
It is hyperacute and within minutes to hours, and accelerated acute within days, acute for weeks, and chronic for months to years.
Okay, don't discuss about duration because not asked. Here asking you about pathological types, because next question will be when does hyperacute rejection occur? You told within minutes. Okay.
Okay. Is it
What happened?
wrong?
ماشي، ما بقولك ما تقولش الدوشن دلوقتي. The question asked what are the pathological types of transplant rejection, you will tell about hyperacute, acute.
Hyperacute, accelerated, and acute and chronic.
Next question, when does hyperacute rejection occur?
At the first hours.
Okay. Next question, what happens to the transplanted organ after hyperacute rejection?
Show infiltration, show some both. I don't know.
In hyperacute, what will happen to the kidney?
Show shrinkage.
Yes.
Okay.
It will happen after raising the clamps and will have swelling at the site of transplant.
Okay.
Patient underwent renal transplant, coming with acute cholecystitis. Post cholecystectomy, the question asked by Dr. Suzanne, what is histological finding of the gallbladder? You will discuss about everything. يعني Haifa told me about ulceration, gangrene, and necrosis, type of the cell, and if malignant transformation, يعني many things about histopathology for acute inflammatory process.
Ulceration, do you mean? Yeah.
لا يعني she told me he's waiting this. No, he's waiting the inflammatory process itself.
Yes,
okay?
exactly.
Okay.
Chronic or chronic or acute?
Acute.
So I
اقرا
say
اللي فوقيها، اقرا السطر اللي فوقيها. Patient underwent renal transplant presented with acute cholecystitis. So what is the histopathological finding in acute cholecystitis?
Polymorphic nucleated leukocytes, as it's acute cells, acute type of acute inflammation.
Yes. Patient presented with abdominal pain, fever, jaundice. What is the diagnosis? Ascending cholangitis. Causes of ascending cholangitis. Patient immunosuppression. This is a question we didn't remember. I only remember I answered retained CBD stone injured caused by surgery and accepted. I don't know يعني استنى. Someone sent me this paper since long time and he wrote me types of rejection. What this since long time. What other organs can develop cyst? Patient now develops cholangitis feature. What are the predisposing factors? I don't know cholangitis feature after doing RCP or not. يعني patient he has retained stone and after finishing of surgery he has or ERCP he has cholangitis feature. So if asking here, number 1 immunocompromised, number 2 retained stone, and number 3
leakage. ممكن abdominal leakage.
Trauma itself. Post traumatic. Till now I don't know. This question asked when? After doing ERCP or before ERCP? If
no,
before,
it's after the ERCP.
Yes, I told Dr. Suzanne this last talk. She refused. But I think this question, by the way, I know this question from my study. I
so
wrote
why did they do the ERCP? What is the indication for ERCP here?
Retained stone.
And what is the presentation for the retained stone here? Is it cholangitis also?
هي اللي دخلت امتحان، بتزعلي ليه؟ هي اللي دخلت، انت بتزعلي ليه؟ طيب. Anyhow, the most important two things يعني like Suzanne told, what is the cause of sepsis for this patient, dehydration, or why there is CBD stone, maybe dehydration because of sepsis. يعني you have according to the situation adjust your answer.
sepsis or dehydration.
عايز 3. لا انا اعتقد، بص انا فاكر السؤال. He wants 3. Why this patient has cholangitis? طب we can go for 1 or 2 of them. Why this patient has cholangitis? Number 1, retained CBD stone or CBD stone because of dehydration and sepsis.
Number 2, renal failure ممكن اصلا.
Immunocompromised, not renal failure, immunocompromised.
الرينال فيلير بتعمل ستونز اصلا يا باشا، بتزود الفوسفورس اصلا.
ماشي.
او الفوسفات يعني.
How the
نتكلم في ان دي
immunosuppression will
فرديه
cause
تانية.
stone.
مش ستون يا سوزان، السؤال ascending cholangitis. listen not stone. ascending cholangitis. you will tell stone in the CBD. stone in the CBD. يعني you can tell stone retained stone in CBD and immunocompromised. The third answer for me is instrumentation, traumatic.
If it is after the ERCP, it could be edema after the ERCP itself. It could be a missed stone after the ERCP then.
طيب تمام. What causes pain we discussed already. I think this is all the question discussed. دكتورة هيفاء, you have any
ممكن نقول يا باشا
question? Wait. دكتورة هيفاء, you have any other question to be added?
No, that's all I remember.
طيب. Mechanism or pathogenesis of acute cholangitis. Some asked me this question. You have two mechanisms or two factors for acute cholangitis: increased bacteria in the bile duct and elevated intraductal pressure in the bile duct that allows translocation of bacteria or endotoxin into the vascular system. Finish this station.
دي بتبقى يا باشا نزود الجزء بتاع اللي هو الانيروبيك نتيجه الانفكشن والاسكيميا، فيعمل لاكتيك اسيدوزس كمان في النقطه دي ولا لا؟
لا مالوش علاقه.
طيب ماشي.
يلا سوزان.
Dr. Hiba.
This is the last station and very important.
السلام عليكم.
وعليكم السلام ورحمة الله. Okay, a 55-year-old IV drug abuser lady for cocaine presented with the left lower limb venous ulcer. Please, could you here define hepatitis C?
It is inflammation of the hepatocyte, and the small bile ductules caused by hepatitis virus C. The transmission mainly by unprotected sex, IVD, intravenous drug abuser, and less commonly to be transmitted through the blood transfusion because usually the blood will be tested before transfusion.
What type hepatitis C virus is?
It is a single-stranded RNA virus from the flavivirus family.
What are the pathological sequences in hepatitis C virus infection?
Acute hepatitis, chronic hepatitis, liver cirrhosis and portal hypertension, liver failure, and hepatocellular carcinoma.
What are the most common risk factors for hepatitis C virus infection?
In this scenario, because of intravenous drug abuser, there is other risk factors like unprotected sex, multiple sex partner, employee in the medical and dental, transfusion of untested blood, and it could be because of recent surgery, major surgery within the last 6 months, needle stick injury, and direct contact with hepatitis C virus infected individuals.
What are the clinical features of hepatitis C virus infection?
It could be presented acutely with fever, jaundice, nausea, vomiting, deranged liver enzyme. Most probably ALT is more than AST. And it could progress chronically with symptoms last for more than 6 months and developing the complications of hepatocellular carcinoma and liver cirrhosis.
Could you define cirrhosis?
It is end-stage liver disease that lead to disruption of hepatocyte or liver parenchyma by fibrous band or regenerative nodules of the hepatocyte.
What are the clinical features and pathological sequences of cirrhosis?
Pathological sequence: hepatocellular carcinoma, The clinical features, we can divide it according to the sequences, portal hypertension, decreased protein synthesis, decreased detoxifications, hepatocellular carcinoma. In portal hypertension, patient may present with portosystemic shunt, which lead to esophageal varices, hemorrhoids, Cabot's medusa, ascites, and hepatorenal syndrome, progressive renal failure. It will be developed, and decreased protein sensitive hypoalbuminemia, reflected as hypoalbuminemia, and coagulopathy because of decreased clotting factor synthesis. Decreased detoxification, patient may present with seizure, coma, confusion, astraxia due to ammonia, could also present it with pulmonary erythema, gynecomastia, and this is because of hyperestrenism, jaundice. I think that's it.
Excellent.
Mr. Zar,
yeah.
May I participate as well?
Sorry?
May I participate as well?
Okay, so take the next question. What is the mechanism of portal hypertension in liver cirrhosis?
Okay, as there will be bands of fibrosis and nodular regeneration. There will be fibrosis of the portal vein. This will increase the vascular resistance, and as pressure equals flow times resistance, any increase in resistance will result in increase in the pressure. And this will eventually lead to portal hypertension.
What is the most common cause of cirrhosis in UK?
Chronic alcoholism.
What is the most common cause of death in cirrhosis?
This will be ruptured esophageal varices.
Define necrosis.
It's unprogrammed, unregulated, and accidental type of cell death in which the cellular membranes fall apart and the cellular contents and enzymes leak outside the cell and eventually will lead to cellular death.
Mention types of necrosis and give an example for each.
Okay, we have coagulative necrosis, which is ischemic infarction in any organ but the brain. As well, we have liquefactive necrosis, which is brain necrosis and can be seen in abscess and in pancreatitis. There's caseous necrosis, which can be seen in tuberculosis, fat necrosis associated with trauma in breast and enzymatic in pancreatitis, fibrinoid necrosis in hypertension, and gangrenous necrosis, such as dry and wet gangrene.
What are the causes of inguinal lymphadenopathy?
It could be classified into systemic and local. The systemic could be further classified into neoplastic and infective. Neoplastic most commonly to be Hodgkin and non-Hodgkin lymphoma, and less commonly could be leukemia. For the infective, it could be tuberculosis or sarcoid. Also, it could be classified to for the local causes, such as infective, such as non-specific reactive lymphadenopathy, which is the more common type of inguinal lymphadenopathy, secondary to infection in the lower limb or the groin. There are specific infections such as lymphoproliferative venereum and cat scratch fever, and also there will be neoplasm. It could be metastatic for a primary tumor in the perianal region or the external genitalia or the lower limb, as well as malignant melanoma.
Excellent. What are the microscopic features for cut section of lymph nodes in hepatitis C virus-related lymphadenopathy?
There will be follicular hyperplasia.
Hiba, where do these changes occur?
In the cortex.
Haifa, what's the type of necrosis in venous ulcer?
It is coagulative necrosis.
Hiba, what are the types of
What
candida do you know?
else? What else?
In the venous ulcer,
Yes.
do you mean liquefactive and granulomatous?
Yes.
Yes.
Okay.
كمل يا سوزان.
Okay, what are the types of candida do you know, Hiba?
Hyphae, pseudo-hyphae, yeast. It could be oral, vaginal, cutaneous, and invasive.
Haifa, what are the stages and classification of venous ulcer?
Okay, this can be classified according to the CEAP classification into 8 classes. From C0, where there is no visible or palpable venous disease, C1, where there is telangiectasia and reticular veins, C2, varicose veins, C3, edema, C4A, mild skin changes due to venous disease such as pigmentation and eczema, C4B, severe skin changes due to venous disease such as dermatosclerosis and atrophy blanchie, C5, healed ulcer, C6, skin changes with active venous ulcer.
Excellent. Hiba, how could IV drug users or abuse cause venous ulcer? Mention 4 pathological processes.
It could be due to repeated trauma due to repeated injection, thrombophlebitis, deep vein thrombosis. It could be chemical due to the irritation of the same drug to the vessels and to the skin. It leads to ulcer and injury.
Excellent.
Accepted also in Cairo. That's the type. Listen, Suzanne. Not accepted. This answer is still not accepted.
Okay.
We will answer this question at the end. كمل يا Suzanne.
What are the complications of blood transfusion, Dr. Haifa?
Okay, it can be classified to immunologic and non-immunologic complications. Immunologic such as acute hemolytic reaction and febrile non-hemolytic reaction, graft versus host disease, and transfusion-related acute lung injury. Non-immunologic such as electrolyte disturbances and hypothermia, and I don't remember actually. Hello?
Yes. كملوا يلا حد يكمل فيه.
Hello, can you hear me?
Yes, we can hear you clearly, Haifa.
So it can be classified to immunologic and non-immunologic.
Okay. Immunological
like acute hemolytic reaction, febrile non-hemolytic reaction, graft versus host disease, and transfusion-related acute lung injury. Non-immunologic such as hypothermia and electrolyte disturbances.
And overload.
Coagulopathy and congestive heart failure.
Overload. Yes.
Okay. Okay.
Okay, Hiba, define massive transfusion.
Replacement of the blood volume of more than 1 blood volume in 24 hours or more than 50% of blood volume in 4 hours.
Haifa, what are the complications of massive blood transfusion?
This could be fluid overload. Also electrolyte disturbances such as hypocalcemia because it's chelated by citrate. Calcium will be chelated by citrate as well as hyperkalemia. There will be also coagulopathy due to deficient factor 5 and activated factor 8 in the stored blood. And there will be thrombocytopenia because of low number of functioning platelets in stored blood. There also will be transfusion-related acute lung injury and hypothermia and multi-organ failure.
Coagulopathy, which means the IC. Go back, Suzanne. Plus, also you forget one of the most common complications of blood transfusion. infections,
Okay.
hepatitis C.
Okay.
Right?
Okay.
We didn't mention this. This is very simple. Okay.
Okay.
You can tell reactions, which can be immunological and non-immunological. This is number one. Number two, infectious or infection like hepatitis B, C can be also.
Okay.
Okay. In hepatitis C virus station, they asked about necrotizing fasciitis and how to differ it from cellulitis. How to differentiate necrotizing fasciitis from cellulitis?
In necrotizing fasciitis, there will be dead tissue and necrotic tissue.
It is aggressive form. It is aggressive form of necrosis, by the way. It will be reach till في equal يا شباب
Sorry.
and can reach till the fascia. Okay.
Okay.
This differentiate. Difference between necrosis and apoptosis.
Yes, in the necrosis, there will be enlarged cell size, and in apoptosis, there will be shrinked cell size. About the nucleus in necrosis.
I think you have the difference between necrosis and apoptosis in the book.
Yes, yes.
طيب. Next. بس معايا شبه شوية. Other part of lymph node rather than cortex. Other type of necrosis, we discussed it already. So regarding of the question, I get very nice feedback of this question. They accepted the answer, which you told about regarding of the ulcer and intravenous drug abusing. In this patient, we discussed about the trauma itself, the effect of chemical effect itself, thrombophlebitis, repeated traumatic irritation because of the drugs. هو ليه في ايكو يا شباب؟ ده السؤال ده مهم. سوزان ميوت اول يا سوزان ميوت اول. Okay. Again, for the question why ulcer can be happened, I will share the screen. Okay. This came in Cairo regarding of IV drug abuser, ulcer. Okay. Thrombophlebitis, DVT, wall thrombosis injection, or like Rahil he wrote here, it's very important also. Venous are destroyed from trauma of repeated injection. This is number one, post-traumatic. Number two, the irritation effect because of the substance like heroin or like chemical. Okay, plus also sclerosis and thrombosis of superficial and deep veins. Examiner waiting one more. Waiting one more. This is the one he is waiting. Just we get it from Cairo exam. That's the time. This patient has hepatitis C. صح يا سوزان؟
Yes.
The patient if has venous hypertension will be increased. So this will cause lower extremity edema, and this will increase capillary permeability, fibrinogen leakage, fibrin cut formation, decrease the O2 absorption and the CO2 removal, so will cause ulcer. Start by this answer. I hope this will be the last time for this question. نبقى كده خلصنا. Yes, loss of pump activity. Clear? This station came in Cairo. I think today most of the station came. 100%. Pathology, which you are complaining of it and needs more time, it will be the best station for you. It will be the best station for you, better than anatomy and critical care. 100%. I know that. Because the station will go exactly like this way without any confusion, except if you have new station. And if a station will be coming from this repeated stations, it will come exactly with this answer. Okay, so pathology will be the best in the exam. Dr. Salah, we are forgetting everything. Just keep information from the mock and the group. I know how this exam is going. Okay, I will stop recording and we can listen for all of you. شكرا دكتور سوزان. من معي بكره سوزان؟ بعد بكره. tomorrow is off. Then we have Thursday, Friday, MOOC 2 and 3. Thursday and Friday. مين دخل يا سوزان Thursday و Friday؟
والله I'm searching دكتور صلاح. I will confirm for you now.
مش لاقيين حد يدخل يعني؟
لا بس I don't know Maria or Murad. One of them picked the day. Just I want to confirm.
Okay. We'll stop recording and can you open mic for them?